and welcome to our MH for All webinar brought to you by the United for Global Mental Health, the Lancet Psychiatry, MHPSS.net, and the Mental Health Innovation Network. For today's session, I am honored to chair the discussion centering on universal health coverage, or UHC, and mental health. Particularly, we hope to dig deeper into the need to increase financing for mental health as well as its impact on UHC. And in addition, we also hope to tackle the role of our civil societies, multilaterals, as well as the global community in driving the meaningful integration of mental health in the UHC. I am equally honored to be joined by a roster of able panelists representing international NGOs and service users, and happy to introduce them. First off, we have today a mental health specialist from the Department of Mental Health and Substance Use from the World Health Organization. Please welcome Daniel Chisholm. We also have today a mental health and psychosocial support coordinator from the USAID, Paul Bolton. And lastly, but definitely not the least, he is the General Secretary of the Cultivation for Users Hope. We welcome Benjamin Hala. So let's keep the ball rolling, perhaps. We can start with Dan Chisholm. Dan, hearing from different perspectives coming from WHO, what are the health impacts of scaling up coverage for mental health as part of UHC, and how costly is it?
Okay, thank you very much, Eve, for your question, and hello everybody. Good morning, good afternoon, good evening, wherever you are. Yeah, my name's Dan Chisholm, joining from the WHO Department of Mental Health and Substance Use. Very happy to be joining today. So to your question, well, I think I could frame it a bit by saying that, you know, when thinking about questions of financing or investment for mental health, I think that can often be broken down or categorized into the kind of the why question, the what question, the how question, and the how much question. So, I mean, I think the first of those, which is, in a way, the kind of the context to your question, you know, the why are well known to us and include, you know, improving the mental health and well-being of individuals and populations, but also reducing inequalities within society, protecting human rights and enabling social and economic development. So these arguments, you know, are familiar to us, but I think we've still got a lot of explaining to do on this front, especially to potentially skeptical entities or parties who might actually be responsible for financing health and welfare services at the national, subnational level. So I think that's an important point to sort of start with, about sort of being clear about what it is that why are we asking for investment in health? What are the real reasons? And then I think your question to me is about the kind of the what and the how much questions. What are the potential impacts? What's it going to cost? And on the impact side, we can, I think, distinguish between the kind of clear health-related benefits of better mental and physical health, but also non-health benefits. And there we're talking about, you know, the increased productivity, for example, that you get from being able to work effectively and return to work after a period of ill health. I mean, there are also other benefits that we could, you know, can think of. Just the intrinsic value of feeling well or not suffering, or indeed the improvement you might get from you know, social networking. But these are much harder to quantify. So look, I mean, the earlier work that we did on cost effectiveness and more recently some return on investment studies carried out in the context of low middle income countries have consistently shown that the health benefits of scaled up treatment coverage for priority mental health conditions, such as psychosis or depression, are really substantial, you know, measured in terms of cases averted, deaths prevented, healthy life years gained. So, I mean, a study a few years back, for example, from the Overseas Development Institute, looking just at low-income countries, showed that an annual investment of just $1 per capita, per head of population, would get, if you put that money into investing into a package of evidence-based care for priority mental health conditions, you'd get roughly 5,000 years extra of healthy life per 1 million population per year. So what does that mean? So, a country with 50 million inhabitants, a big country, that investment of around $1 per head could translate to around 250,000 extra years of healthy life per year. So very, very substantial. And of course, the new briefing that's come out from United for Global Mental Health goes one step further and sort of calculates the cumulative gains that you'd get if governments across the world attained the kind of targets that's in the WHO Global Mental Health Action Plan, which is a 50% increase in coverage by 2030. And that leads to, I think I've got it here, 24 million healthy life years gained, 50 million cases averted, and nearly 500,000 deaths averted. So very substantial amounts. And what about the cost? These are very low in absolute terms. So for example, I mentioned, $1 per capita. And several studies have found even lower estimates, than that. And this new paper estimates an incremental additional cost in expenditure of just around 20 US cents per capita until 2030 would get us up to those kind of targets that we're just mentioning. And those amounts are tiny, when you compare it to the economic costs or burden of mental health conditions. But for many low income, that might still represent quite a relatively large step increase in the amount they're currently allocating, which of course are very, very meager. So that's the answer. And maybe we'll come back to the how question a bit later in the discussion. So thanks a lot.
Definitely, Dan. And thank you for sharing with us how massive it can actually be in terms of investment, but the outcomes are really, really encouraging. I can really speak for my country, the Philippines, as we're also a recipient of the investment case on mental health by WHO and UNDP. Now, hearing from WHO, let's hear it this time from USAID. Paul, why does USAID champion the integration of mental health into primary health care? And what is its importance of having such an integrated approach?
Sorry, I had myself on mute. Trying to be a good citizen here. So look, thanks, Eve, for the question. Thanks for having me today. So I'm Paul Bolton, and I'm the USAID Mental Health and Psychosocial Support Coordinator. And I'm actually the first person to hold this job. I've been on board since October 2020, and just my mere employment represents a expanded commitment by USAID on mental health. And so we're actually just getting into this field at the moment in terms, not so much in terms of funding, because we've been funding mental health and psychosocial programs for many years now, but trying to do it in a more thoughtful and structured and strategic way in coordination with the rest of the global mental health community. So that said, the first thing I have to say is that that my comments today actually represent my own plans and the plans of my colleagues within USAID, and don't represent the agency policy or practice. And the reason for that is we don't yet have an agency policy or practice. We're actually in the process of developing both. So everything I say here today refers to our plans that we're putting into place and what you can expect from USAID in the future, but that we don't yet have. So early days yet. So why champion the integration of mental health into primary healthcare? That's exactly what USAID is one of our initiatives. This is what we're trying to do as a way of expanding mental health services. The first reason is we think this is likely the best way to reach people with mental health conditions. If we try to set up separate mental health services, the stigma associated with mental illness and seeking treatment will prevent people from using these services. And we've seen this all over the world. So we know that people are just more likely to come to primary healthcare services and therefore more likely to be diagnosed and contact and take up any mental health services that are offered. The second reason is that there's so much comorbidity between mental and physical health problems, and they affect each other. So for example, we know depression and substance abuse affect nutrition. And so identifying and treating all three, depression, substance abuse, and nutrition directly, is going to be a lot more effective than just trying to treat nutrition alone. And we could say that about a whole other things, a lot of things that are affected by mental health. Better to deal with the mental health and the issue collectively than separately. Another reason is we want to improve the accuracy of diagnosis. When you have separate mental health and physical health programs, this can lead to misdiagnosis. For example, the symptoms of depression look similar to those of anemia and other nutritional disorders. So someone with anemia presenting to a whole separate mental health program could well be misdiagnosed as having depression rather than having anemia. So you need someone who is trained in both physical and mental health, which is what we plan for primary healthcare providers to be able to do. And that person would be better able to detect and distinguish between physical and mental health problems. And finally, for USAID, there's just the problem of siloed funding. We just have separate funding to address separate issues. We have separate programs for TB, we have separate programs for HIV, we have separate programs for nutrition, violence. And even though that's what we have, it's not a system that anyone really would have wanted. It's a result of how our Congress determines and allocates money for overseas programming. But having separate programs for different health issues is inefficient. It's inefficient for us as the funder. It's inefficient for providers because you have to have a whole bunch of different providers. And it's inefficient for the population, right? If you have one problem, you go to one place. If you have another problem, you go to another place, and none of them talk to each other. So within USAID, there's a movement towards less siloing, and our best approach to having less siloing, excuse me, is to focus on primary healthcare, where health issues are dealt with collectively. I'm going to stop there and willing to go in whatever direction folks want according to the subsequent questions, but thanks very much.
Thank you, Paul, and thank you for sharing with us some insights from the USAID's perspective, especially on addressing silos and going for primary healthcare as the way forward in mental health. Let's now shift to Benjamin. Hi, Benjamin. What has been your experience as a service user in navigating mental health services? So we've heard it from the systems level, from the policy level, but we're really curious about the perspective as well of the service user. And are these mental health services in your country considered affordable and even accessible?
Yes, good afternoon, everyone from my end. All right, here in Liberia, my experience as a service user is Liberia as a low and middle income country is very difficult, knowing the state we come from. We come from war, we enter Ebola, and now the pandemic, the COVID is very, very difficult here in Liberia, especially when it comes to financing. Our government is not doing much for persons with live experience, let's say for the disabled community, especially persons with psychosocial disability. Last year, due to our advocacy from the live experience point, by 2019, about 2 years ago, we staged a petition ceremony at the Capitol, at the House of Parliament, and that story, United Global Mental Health No Best, that was the first time for our government to allot a dime for mental health services in Liberia. So from there, we came on to this fiscal year. The budget is almost about to be passed. We advocated and stated there's no avail. From 25,000 US dollar, they have increased that to 50,000 US dollar for persons of 5 million population. That's too much. And you see psychosocial problems all over the country. So we are advocating, we are working, but in terms of financing from our own government side, it's on a slow pace. But we must commend the partners, especially when it comes to WHO and MSF, Cara Center, Partners in Health. They have been there for us. And from our own end, because of our capacity as a service user, we were able to partner with two different organizations, that's Labrador Association of Psychosocial Services and the LADCOM, which is Research in Mental Health. We partner with them and we wrote a proposal to OSIWA. That was back in 2019, and we were able to solicit a fund to run a project for our colleagues in the West Point and the Dole community. That project we started working on, and we concluded that in 2020. So this year they came back with a pilot project to better sustain our own organization to make sure that they saw the need of the work that we do. So they came back to buttress our effort for sustainability. And that project is ongoing. It's going on for 2 years. We should be ending that project by next year. So that's all I can say for mental health services in Liberia. It's not an easy thing here in Liberia, Guinea, Sierra Leone. It's not an easy thing for service user. We go through a lot. For me, I still survive on medication. Most of the time, medications are not available. But we must commend the partners, especially MSF, Medicine Sans Frontiers, MSF France. They have been doing very well for us, our service users in this country, and they stay doing well. But there's still more to be done because in the rural areas, we have series of relapses and there's no medication. We receive those calls from the rural areas every time talking about medication issue. But we are not into treatment. We only advocate with those that provide the services. So we stay into it. We are here advocating, making sure that mental health can be included into the general health system. If you can provide HIV and AIDS medication free of charge, but here in Liberia it's paid for. Only partners that allow us to access the medication free. So financing in mental health is still a problem. Recently, Cara Center we staged mental health champions, a group initiative. So this group is going all out to search for funding where we can help to promote mental health services in our own country and even the sub-region if possible, maybe the nearby Sierra Leone. So mental health is a challenge in Liberia. So that's all I can say for now. It's not easy to advocate here in Liberia. Our lawmakers are not willing to listen, but they put a lot of money to where the money not supposed to be. A country of about 5 million population is psychosocial problem all over the country. We have 50,000 United States data. That's too little. It doesn't even provide medication for even a month. Thank you so much. That's what I can say. Thank you.
Thank you so much, Benjamin, for walking us through the different pain points of being a service user, and hands down to your efforts, despite these challenges, still pushing for better financing and mental health in Liberia. Interesting insights on both the perspective of a systems level integration and even at the service user perspective. And as we all know, financing is inevitable not to be discussed. So earlier, Dan mentioned the health and the economic impact of financing mental health in the UHC scheme. So the what. Let's now talk about the how. So Dan, what are the best ways in which mental health can be financed as part of the universal health coverage?
Okay, thank you very much, Eve. And I think the first thing I want to say is, just react to what Benjamin just said about current allocation in country like Liberia, and this is what we need to keep in sharp focus when discussing these issues. That it's just unacceptably low amount of expenditure. $50,000 divided by 5 million. That's like one cent per capita, isn't it? It's a tiny amount, completely inadequate. So what do we do about that? So yeah, indeed, the question that you are asking very much around the how, and the new briefing that you can find in the chat now, I see, it does set out some of the key considerations and options that can be open to countries. So I'll follow that structure and just go through those a bit, are those three main mechanisms that have been identified there. So the first one, so UHC, I mean, it's been around, as the paper says, it's been around since the, for decades, but it's sort of become a sort of a rallying cry and a a kind of unifying goal of health systems, and that's great, because it has galvanized a lot of countries into rethinking and replanning, particularly the way that they organize, but also finance health services. So as they're doing, as countries are doing that, and there's quite a lot of doing it right now, this is a crucial opportunity to ensure that mental health is part of the thinking, the planning, and the sort of the packaging of different essential services and inclusion in insurance schemes. So I mean, this is for example what Ukraine was doing, just very recently until their country was invaded. But that's just one of many which are going through this systematic process of replanning their health systems, financing systems. So on the WHO side, it has something called the UHC Compendium, which contains a large number of programmatic elements from which countries can choose, for these kind of packaging, essential packaging purposes. So that's one useful tool that countries can make use of. But of course, most of the action will be at a national level of planning and dialogue. And here, I think having some contextualized estimates of the expected costs and benefits will certainly help. Just like hopefully it is in places like the Philippines, where we've done a recent national mental health investment case. There's other countries, Bangladesh and Nepal, and then in Africa, studies are just being finished now in Kenya, Uganda, and Zimbabwe. So I think this is an encouraging sign that can help open some new doors, give some new ideas about how much is the amount and what are the ways, and sort of force a discussion about how that could come about. So that's one. The second one is more the kind of higher level, the kind of more broad national development plan. So a lot of countries, again, beyond UHC. So, we talk about incorporating mental health in health, in health insurance schemes or health financing. But what about thinking a bit beyond the health sector? And here I think, mental health can be positioned and considered as an emerging development priority for many countries, just because it is linked to poverty, to social inequalities, to migration, to COVID, to Ebola, you name it. There is an important mental health dimension to many of these pressing concerns and priorities for development partners more generally. So in this way, mental health can be brought into these broader development strategies, and those often inform treasury decisions, not just in the short term, what's happening the next year, but the next 5 years. These sort of medium-term budgetary frameworks, which a lot of countries use. So that's another opportunity. And of course, the third one is external finance. The donors. And that is particularly important in the least developed and lowest income countries, because as we just heard from Liberia, the budgetary pressures there are greatest, and therefore the amounts made available for important programs like mental health are just vanishingly small. So, I mean, they can also be useful for middle-income countries. For example, if a middle-income country really wants to deinstitutionalize and develop community-based, they often will need some support to do that, to manage that process. And the source of external funds is quite varied. I mean, it could be philanthropy, it could be bilateral agencies, or multilateral donor funds. So Paul may be able to say more about from USAID front. But I mean, there is indeed, I mean, you know, partly because of the pandemic, I mean, there is increasing awareness, interest, and therefore appetite and commitment to mental health from governments as well as multilateral donors. So there is again a window of opportunity here that we have to walk through and step in. So, I mean, some of the big existing ones would be like the Global Fund for AIDS, TB, and malaria. You know, this is dispersing billions a year, 4 billion a year. They just had a big replenishment meeting. Another one, Global Financing Facility, which focuses more on maternal, newborn, child, and adolescent health. So these are big existing entities where, again, links can be made to the mental health dimensions of communicable diseases or adolescent health, maternal health. It's so clear again to us, but it's quite hard actually to get the messages across. And then there's more bespoke ones, like there's this new Health for Life Fund. So this is focused on, it's a new multi-partner trust fund focusing on NCDs, non-communicable diseases, and mental health. It's been set up under the auspices of an interagency NCD task force, and is hoping to mobilize nothing like 4 billion, mobilize and disperse around $250 million over 5 years. So at least that is a bit more directed, and we'll get a share of that pie. So these are three of the main kind of channels or mechanisms for getting mental health more appropriately financed as part of UHC. Back to you.
Thank you very much. Thank you very much, Dan. So there really are lots of bits and pieces moving all together at the level of the World Health Organization, but really have to maximize and leverage on those opportunities. And what strikes me, by the way, is pushing the discussions beyond the health sector. It highlights the intersectionality nature of mental health, especially in integration to the universal health coverage. Thank you, Dan. Going to Paul, building on what Dan had mentioned earlier, and diving deeper into what you also shared earlier, what are USAID's plan for the integration of mental health into the primary healthcare? And what needs to be done to influence global financing for mental health?
Thanks, Ed. Well, regarding integration of mental health into primary healthcare, I mean, at present, I'm working with colleagues inside USAID and external experts on a primary mental healthcare approach that is intended to build on MHGAP. MHGAP trains primary healthcare workers to provide diagnosis and medicine-based treatments, but it doesn't provide psychotherapy. And this is understandable since psychotherapy is time-consuming and requires a different set of skills. But most mental health conditions respond well to psychotherapy, and therefore we feel it's important that people have access to this kind of treatment as well. We know that asking doctors and nurses and other existing primary healthcare workers to provide these services has not worked out well, at least not in my experience. And so treatment of mental health problems is more time consuming than many physical disorders and requires skill sets that are much different from physical healthcare. And so these kind of workers like doctors and nurses, when they get busy, frankly, mental health care is the first activity that they stop doing. It's the first thing that they drop. So we're advocating actually for full-time trained local providers of psychotherapy for communities. Primary healthcare providers can then, using MHGAP, refer people for treatment, psychotherapeutic treatment to these providers. And we know from the last 20 years of research and practice that non-mental health professionals can learn to provide these treatments effectively if those workers have the proper training and supervision. And it's important that these providers be local and that they work full-time in order that these services are maintained. But, you know, as you can imagine, I mean, if we're pushing this approach, I mean, that's expensive. We're certainly not going to get very far on 1 cent per person. Budgets like that. So we just have no choice but to expand the available funds. And how do we do that? I mean, one is, you know, what Dan was talking about, the first approach, which is to continue to accumulate and publicize evidence on the direct effects of mental health problems on mortality and disability, and what these programs would cost. For example, we know that mental, neurological, and substance abuse disorders cause about 1/3 of global disability. We know that suicide alone kills more people than HIV or malaria, and yet these, mental health gets a tiny fraction of what is allocated to these programs. So there's a strong argument for increased direct funding of mental health. But even more than this, we have a lot of evidence that mental health conditions adversely affect other health outcomes, such as TB, HIV, non-communicable diseases, as Dan was saying, nutrition, early childhood development, violence, and so on. And mental health conditions affect whether people take advantage of programs that address these problems. For example, we know from a previous United for Global Mental Health report on TB that people with TB are 4 times more likely to die if they have depression, and 9 times more likely to be lost to follow-up. So there's a strong argument that physical health programs should include mental health services to make the physical health services more effective. And so advocating and demonstrating that these programs should support mental health as part of their services is, I think, an important approach to funding mental health overall. In fact, I think that this could be part of one of the most important sources of mental health funding in the future. It's partly because these programs have access to much larger amounts of money, as I mentioned, but it's also because it would put mental health services in the position of supporting these other services rather than competing or seeming to compete with them. And so in the work and advocacy that I've done within the agency, I have developed reviews of what are the links between mental health and TB, HIV, nutrition, violence, youth, etc. And advocating that if we're focused on outcomes, on better nutrition, better HIV outcomes, better whatever outcomes, that mental health services should be part of this. And we're starting to get some success in this. We're starting to get our programs talking to us, and we're starting to develop program guidelines that are incorporating mental health. So I'm hoping that at least within USAID, you're going to see a lot more of this in the future. Thanks.
Thanks, Paul, and exciting times ahead indeed. Thank you for highlighting the use of MHGAP as a tool to further capacitate our mental health frontliners on the ground, and for further solidifying on the cross-cutting nature of mental health. Now we move to Benjamin. So we have tackled a lot of what can be done at the systems level, particularly policies and financing. And it's also good to hear from someone who's at the core of our advocacy, which are the people or the patients. So as a service user, what would your message be? We know that you highlighted earlier different pain points. So what would your message be to the government regarding integrating mental health into universal health coverage?
All right. For us, as from the service user end, we will be pushing. Number one thing there is policy. So we are working on the Mental Health Act along with the CADA Center. Once the act is passed by law, we can hold the government feet to the fire to tell them that this should be done for mental health. That's one. And the mental health law has been passed into sound with the help of the CADA Center and Cultivation for Users Hope, the mental health unit. That act has been passed. That's one. So we're going to be pushing for our government to do more for mental health. Most of the time in my advocacy, I try to tell government workers or government officials that assuming there is no partner, so you're going to allow your citizens to just roam about the street and going to die. So we want our government to do more to make sure that mental health can be included into universal health coverage. Mental health can be included in the general health system. Treat mental health as you treat your malaria, treat mental health as you treat headache or typhoid and all of that. So that's how we want mental health to be in our own country and even the world at large. So mental health for a very period of long time, mental health have been under the rock, but this time we need to advocate that mental health is everybody's business. Remember, at any point in time of anyone's life, You can be mentally disabled. So mental health is not a joke. So we telling our government, please do more for mental health. As Dan was saying, 50,000 is just a mockery of the health system. You cannot have a resilient health system when you're leaving mental health behind. So we need to have mental health included in all health system. And in doing that, we need to have the right people, the right logistic to make sure we do that. And you can't do this without persons with live experience, because I wear the shoes and I know where the shoe pinches. So if I don't have medication, you're not going to see me here sitting and talking to you. It will be a different story. Most of us survive on medication, and medication is helping us a lot. If there's no money, government not going to procure medication. And also to the partners, you need to have the right people. If you think giving the money to government is causing problems, there's no proper accountability, then you find, I'm talking about the international donors, that the UN, the WHO, and all of that, find the right partners or international organizations, NGOs that can help us do this to make sure that mental health is included. If you think giving the money to government is causing problems, then find the right international organizations to work along with service users, and we make this happen. Thank you so much.
Thank you very much, Benjamin. Those are really empowering words. And keep the fire burning in Liberia. And this is no longer the time really for mental health to be put on the sideline. So it's high time for government to act. Thank you very much. We now move actually to a question and answer. Hearing questions from our audience joining us today. So for the first question, let me just pull it through. This one's for Paul. So Paul, while integration with primary healthcare makes sense for improving access, for people experiencing depression and anxiety, what about the need for specialized services for some conditions such as substance abuse or even schizophrenia? Paul?
Yeah, I mean, one of the problems that we have is that in many parts of the world, there's not access to specialized services, or not ready access. And then in many countries, where we have specialized services, they're all concentrated in the capital city, and other parts of the country don't really have access to them. So there's a couple of things that we're working on collectively here. I'm not just talking about USAID, but global mental health community. And one is, and I should mention a third thing, which is that very often a large part of mental health budgets go into specialized psychiatric hospitals, right? So when you talk about how little countries are allocating to mental health, and then you realize that most of that little bit is going to the psychiatric hospital, you realize that there's not much left for other kinds of services. So there's a push to move these services to be closer to the community. So primary healthcare is obviously part of that, bring it into the community. But what we'd also like to do is to focus less on having specialized psychiatric hospitals and more having district hospitals that have psychiatric capacity, so that those beds go from being all concentrated in one place to being more readily available. So we'd like to see district hospitals that have doctors and nurses that are trained in psychiatry, and either have psychiatrists there or have them accessible by phone or internet. And so therefore, in the primary healthcare system, when somebody, the primary healthcare provider and the primary mental health provider that I mentioned before, when they see someone who has schizophrenia or some severe illness, they can refer them, not so much to the capital city, but to wherever the local district hospital is, and therefore increase access that way.
Thank you so much, Paul. So indeed, that's really a vision that we can share, wherein mental health services should be as easy as ordering a pizza or getting food by your doorsteps. Thank you. This one's for Dan. Does the United Nations Convention on the Rights of the Disabled provide a lever for investment in community-based services and housing?
Yeah, okay, thanks for the question, Steve. just before I get to that, I mean, very much, align with what Paul just said about, MH-gap, he mentioned, and of course it includes substance use, psychosis, dementia, which, some might seem, very challenging conditions to manage at a primary care level. I think it requires, discussion on a one-by-one basis. Each country is different, and what could be possible. But in some instances, providing some training and identification to enable better referral to more specialized services, is one way to go. But so I just wanted to say that. On the question on the CRPD, so the Convention on the Rights of Persons with Disability, this is a fundamentally important document in the area for public mental health, as well as other related fields in disability. I was going to mention the WHO quality rights here, because this whole toolkit and the related materials is all based, in fact, on the CRPD. So it's kind of trying to articulate and provide tools that can be used at country level to actually implement services and policies that are in line with the CRPD. This is quite a substantial program. Maybe one of our United colleagues could put the link in the chat for those who want to look into a bit more detail at that. And so we're working in a lot of countries. There's a lot of interest in using a rights-based approach to transforming the mental health agenda. It works very powerfully in some countries, but not all. I mean, in some countries, the human rights line would not necessarily be as successful as other channels or approaches. So I think we need to be, in that sense, rather agile and flexible. When we're talking about making investment, trying to build in political engagement, then we need to have a number of cards, or at our disposal, and other arguments up our sleeve. That could be economic, it could be around social inclusion, it could be about human rights. So we need to get good at having these ready to hand out at a moment's notice. So I'll stop there.
Thank you very much, Dan. And those cards more or less like your social determinants of mental health. And I'm also happy to note that the WHO is actually also launching the quality rights training for mental health. So I think that's a good tool to actually explore further. This one's for Benjamin. Benjamin, what more would you want organizations such as WHO, USAID guys joining us today to support work at the national level, such as in Liberia? You want to hear it from you?
Yes, okay. For us in we have Bagon. He's a very good mental health clinician. He works with WHO. So he's also there pushing for service user, but it's not going to work. It's not an event, it's a process. Gradually, WHO is working in Liberia. We in contact with the office here in Liberia. So this is a process. Gradually, we are fighting. As I said, we will continue pushing and advocating and making sure that mental health will one day be included in the universal health coverage and in the general health system here in Liberia. So it's not an easy task, but we are working along with the partners. Like we talk about the United Nations Convention on the Rights of Persons with Disability. Yes, we also working on that. And like yesterday, we had a meeting. Our organization, the leadership, had a meeting with the Cara Center program lead here for the mental health program in Liberia, and we were discussing the quality right toolkit. We had a training before, so we want to do it as a refresher again, and to make sure that at the end of the year, cultivation for users who can come up with a report, with a quality right to get this, with a report that other people can see what is really happening in Liberia. So we're working on that gradually. As soon as Atlanta Carter Center have approved that particular proposal, we're going to be working on that quality right to make sure that we do that training again. And we're going to be moving to universities to make sure that we can have interns, and also so that they will be able to research for us and give us some data that we can put out there, so that international partners will see the clear picture of what's happening, what really we are doing, and what's happening in Liberia for mental health. So those are the things that we are planning, but it's going to be on a slow pace. As you know, funding for mental health in Liberia is a challenge. So gradually we are getting there.
Thank you very much, Benjamin. And indeed, the seeds have been planted, and hopefully you can increase your fold further, and encouraging the government and even the different partners, both at the international and local space, to actually push for better financing in mental health. I won't forgive myself if I would fail to ask this question, being a very relevant topic, but this one's for that. How would the Ukraine crisis impact the call for greater financing for mental health?
Do you mean in Ukraine or more generally in Europe or global? What can you just specify what you mean?
The question here mentioned about the Ukraine crisis.
So the Ukraine crisis, of course, has shocked everyone deeply, and has led, of course, to a rapid response, including mental health and psychosocial support response, both in the countries, in Ukraine itself, of course, but also in the affected neighboring countries, the vast numbers of millions of people have been displaced from their homes. I mean, the one good news is that that we already had quite strong MHPSS capacity in the country, because this is not a new war. It's been going on for 8 years in the east of the country. And so because of that and the internal displacement, there's really quite a substantial amount of existing MHPSS capacity built and materials. So it wasn't a standing start, I can say. And of course, the different partners who were already active there have been now joined by dozens of new ones, and a concern, when you have such an emergency, is that you have problems of coordination. And so here the interagency reference group, interagency standing committee, has a MHPSS reference group, which is providing that sort of coordination across more than 50 different organizations. So I think that's been extremely important as well during the COVID pandemic. They were very quick to develop and issue and distribute very relevant materials for a lot of countries. I think, this is a local emergency which has now gone across many borders. It's not as diffuse as the COVID pandemic, which arguably did even, at a global level, did more damage to the mental health of populations and many specific affected groups. And that has certainly led to greater awareness, attention, interest, and let's say political commitment. But the big missing piece here is what we're talking about today, which is the actual financial commitment of governments and the UN and other entities in this area. So the work is never over, and we have a long way to go. But at least we have more awareness and attention than we did 5 or 10 years ago, and conversations are happening. Our director, Devorah Kestel, was in New York last week at a session of the UN Security Council, where they were talking about mental health and psychosocial support. I mean, you know, that wouldn't have happened. And so the world is changing, but it's a long way to go.
Thank you, Dad. And we pray for our brothers and sisters in Ukraine. But I'm moved also by the spirit of solidarity of different groups offering MHPSS. But as Dad mentioned, I would re-echo that to also be in the form of financial support for mental health services. This one's would be the last question from our audience. So this is for Paul. I actually combined the two questions. So as you know, USAID is moving into the mental health space. So what are the biggest challenges that you think the agency will face? And second, is there a room for the global community in getting involved or influence the planning of USAID? And how can they do so?
Wow, what a question. The biggest challenge we face, or there's several. So a big challenge we
biggest
face
challenge.
is that Congress earmarks what we spend money on. And so Congress says, you will spend money on HIV, you will spend money on TB, you will spend money on nutrition, you will spend money on early child. And once they've finished with all of those earmarks, there's very often little or no money left for any discretion. And to be frank, many of our members of Congress, their ideas on what the world needs, what are the priority issues, are firmly rooted in the 20th century. And this is the 21st century. And so we have learned much of what we learned about global mental health in all of our communities around the world was really developed and put together in the 21st century, and they're just way behind. So we need to advocate for Congress to actually make a space for mental health and make a space for, you know, what we can do. The other thing, as I mentioned earlier, was we can look at those existing earmarks and say, well, actually, mental health should be a huge part of HIV programming. And we should be spending a fair chunk of HIV money on mental health programming. And so working within the current earmarks that we have, because everything to do with changing funding and Congress and making new laws and directives takes so long that we have to do both. Advocate to Congress to change the earmarks, but work within the earmarks as we find them. But I want to say something more general, which is just before I came to USAID, I worked for many years in global mental health, and many of people, my colleagues, we talk about this. And I think one of the issues is that as humans, we're kind of prejudiced against mental health. You know, I can talk with colleagues about these figures that Dan put together and that United for Global Mental Health has put together, that if we just talked about, look, there's this disease X or there's this problem X that causes these things, and we made a case, people were like, yeah, we should absolutely address that thing. But then when I say, well, actually X is mental health, then they're like, oh, okay. Then the sort of, you can palpably see the interest reduce. It's like, oh, that's what you're talking about. And so I feel like in many ways at a human level, we need to confront our own prejudice against mental illness and say, look at the figures. This is worth investing in. And so, and in terms of people who've lived experience, for example, right? We know that they suffer a whole lot of prejudice in terms of their ability to function, in terms of like people giving them responsibility. Even within our own agency, we need to be more upfront about our own staff and our own people about, you know, people who experience mental health issues. Who are your neighbors? Who are your friends? Who are your brothers and sisters? In other words, we need a greater exposure amongst ourselves to people with lived experience and try to overcome this natural, and I think it is almost a natural prejudice against mental health. And I really feel that across the board, that's what's sort of dragging us back to acknowledging these issues and giving them their proper attention. I'm sorry if that was a little off board, but you know, half my job is talking to people who are not interested in mental health and trying to get them interested in mental health and get them interested in funding mental health. And this is just what I repeatedly see, is that there's just this natural bias against mental health that we have to overcome.
Thank you very much, Paul. But I think that's a very valid point. I share the same experience talking with policymakers on how they would see mental health programs as means or vehicles for vote generation. But again, there's a long way ahead for us to continue these discussions. And wow, there's been so much to note from our discussions. I would re-echo what Ali mentioned. Amazing questions indeed. And we can't get enough of the takeaways. And what better way to cap this off than through our tweet length parting words? So it's more like a fast talk to our panelists. So panelists, in a very brief manner, here's our $1,000,000 question. Why should we scale up financial coverage for mental health as part of UHC? Perhaps we can start with Dan.
With me? Okay. Just before I come to the tweet, just to kind of alert people that WHO will produce, we're finalizing the production of a World Mental Health Report, which will be coming out in a few months' time. And it is squarely targeted at decision makers, policy makers at national level, with a focus on lower middle income countries. So we hope that this will set out all of the arguments as well as the evidence and options that countries can take. So I just want to flag that, and maybe we can have a separate session on that sometime later in the year. But back to the tweets. Well, I couldn't fit it into one, so I've come up with two. So why should we scale up financial coverage for mental health as part of UHC? First one I had, because individuals and families affected by mental health conditions are being unfairly penalized and prevented from accessing or receiving the treatment and care that they are entitled to. And then a slightly different formulation, which is number two, is mental health and access to mental health care is a basic human right. In fact, therefore, families should not be impoverished as a result of mental ill health. Those are my two.
Great. Thank you very much, Dan. So rights for all. How about Benjamin?
I think Dan answered it all, but I'll just add up to buttress what he have to say. We as service users, our rights have been violated by this health system. Look at country like Liberia. We have a psychiatric hospital that have about 80 beds for just inpatient. That's a mockery of health system, especially in Liberia, where you have people relapsing all over the day. Every day we receive about 4 or 5 calls. People want to go to the psychiatric hospital with their loved one. Even currently, I have a client right now waiting to go to the psychiatric hospital, but there is no finance. And the families are not able to take those people to the psychiatric hospital. Psychiatric hospital now is like a private hospital in Liberia where you don't have the cash, you are not able to take your loved one there. So I think we need to do more for mental health to be included in universal health coverage, so that persons with mental health condition that can afford will be able to access treatment at all level. At all level in Liberia, mental health areas, psychosocial hospitals are now all over the place, so people relapse all over. So if we do this, you're gonna have people accessing treatment, and our rights will be restored. So thank you so much.
Thank you, Benjamin. No ifs, no buts. If you care about your people, care about their mental health. And definitely, but not the least, Paul.
I had a few thoughts. I was thinking more of our, funding audience within our own agency and government, but more generally, I was thinking one tweet would be from President Biden, who said that mental health is health, period. End of argument. And to that, I would add, look around you. Mental health is your fathers and mothers, your brothers and sisters, your children, right? If you withhold mental health from withholding mental health is basically withholding healthcare from them. That's it.
Thank you. Thank you, Paul, Dan, Benjamin. Wow, absolutely enriching discussion. Again, thank you to our panelists for today. The message conveyed is clear. Here's my tweet. There is no universal health without mental health. And may we all be our own versions of catalysts for change in the mental health landscape in order to make this happen. And I have some good news for you. You can learn more about the impact of financing in the integration of mental health in the UHC through our UHC 2030 brief, which our friends from United for Global Mental Health have prepared and are more than happy to share. Meanwhile, watch out for yet another interesting MH for All topic soon, and let's keep the conversations going in the online sphere. Use the hashtag MH for All. And for the next months, we'll be discussing mental health and climate change. To everyone, our most heartfelt thanks for taking the time to tune in today. And this has been Ives from Mental Health PH, your chair for today, and see you in our next webinar.